Good morning, everyone, and welcome to our RSNA 2025 Power Breakfast hosted by Philips and 4D Medical in partnership with clinicians from the University of Miami and Duke University. I'm Matt Tucker. I'm your facilitator for this session, and thank you first and foremost for joining us bright and early today. So the events today, we're talking about CTVQ, ventilation and perfusion imaging from your existing non-contrast CT. It's about a groundbreaking shift from anatomical images to actionable cardiopulmonary function available from the CT imaging we're already performing every day. This morning, you're going to hear from experts across radiology, pulmonology, informatics. We were going to hear about the VA system and industry, all seated here on stage as we walk through the technology, the evidence, the workflow integration, and the enterprise strategy that is making functional lung imaging broadly accessible. So let me briefly introduce our panelists. To my left here is Dr. Greg Mogul, who's the Chief Medical Officer at 4D Medical and a practicing radiologist. Next is Dr. Trishul Siddharthan. He's a pulmonologist at the University of Miami. Dr. Joe Mamarapapil is a cardiothoracic radiologist from Duke University, and then James Woods, who's the Vice President and Head of Enterprise Informatics at Philips Healthcare North America. Unfortunately, the snow has defeated us with Dr. Amy Rose, who is the critical care specialist and physician clinical champion at Philips. So to start with, we need to understand the engine behind CTVQ. So how we derive functional ventilation and perfusion maps from a standard non-contrast CT scan. Greg has been central to shaping this technology and its development, and he's going to help walk us through the evolution from anatomical to functional chest CT and why perfusion in particular matters for clinicians who rely on actionable pulmonary information. So Greg, with that foundation, maybe you could start us off.
Absolutely. I hope I can be heard. It feels like my voice is being projected. Good morning, everyone, and welcome. I think the most important first thing to understand, and I've found now after talking to thousands of practicing clinicians, radiologists, and others, that that this can't be emphasized enough. That fundamentally, we take a non-contrast CT scan, as shown here, with an inspiratory and expiratory phase on any equipment, any CT scanner that you're routinely using with no exotic, unusual protocol. We can use low dose, below lung cancer screening doses and acquire that image, and then entirely without any inhaled or injected contrast in a standard way, even retrospectively, take that image and with processing, develop a fully realized both subjective and quantitative evaluation of the ventilation and perfusion regionally in the patient. I've given this presentation, as I said, to several groups of folks, and sometimes I notice they come back a few weeks later and say, remind me what kind of contrast you used. And so this is the point I always want to make, that there is none. So that can't be said too much. The next question that I almost always get is, how? How do you do this? How can you get perfusion information from non-contrast CT? And I would advance to the next slide if this works. So I'm going to ask someone to advance to the next slide for me. The key behind extracting perfusion information from a non-contrast CT is actually extracting the ventilation image from a non-contrast CT. Evaluating ventilation on non-contrast CT, both from an inspiratory, expiratory paired image, is actually what we at 4D have been doing for years. We have a globally cleared, clinically active tool to quantitatively evaluate ventilation changes across the lung at a voxel by voxel basis. This uses a foundational technology called velocimetry, which essentially tracks the movement of structures from inspiration to expiration, and from that develops a highly detailed map of actual airflow from the CT scan. And so what happens is, if you can meticulously remove all of the structural changes that occur in a CT scan down to the mathematical level at the transform layer, you actually do end up with a small amount of relative change that's mathematically evident, but not something we can visually do in the lungs. And that change is due effectively to perfusion in each area of the lung. So once the ventilation is subtracted, the changes in perfusion, which we inherently know as radiologists have, there is perfusion information on a non-contrast CT. We learned that early. We learned that the vessels can be pruned. We learned that there can be mosaic attenuation where the perfusion is different. But we kind of quickly forget that, because from a functional clinical perspective, our eyes get lost in that change because of all the changes due to the airflow. So subtracting the airflow and then analyzing what's left essentially gives you a highly detailed perfusion map of each region of the lung. Critically, I want to say, proudly, I want to say, that this technology is not based on machine learning. This technology is not trained from a specific demographic, which, as you know, leads to both training biases, demographic biases, and outcome. We can do the math. We can show you the math. We are Blue Book style, not AI style, and so it's there, and it works across any population. Next slide, please. It's really important to point out the output of what we provide. So we provide a report that critically contains quantitative information. If you look at the vast majority of nuclear medicine imaging or dual energy CT imaging, the common ways today of providing perfusion information about the lungs, very few, only SPECT CT VQ, which is the highest level of nuclear medicine VQ, provides reliable quantitative information. And our clinical colleagues, like Dr. Siddharthan, find that information, the critical information in making decisions about treatment, pre-treatment planning, post-treatment evaluation, and how to intervene in a wide variety of diseases. We also provide a set of subjective images that to a radiologist would look something like a PET CT. There is an overlaid heat map demonstrating ventilation, as you can see at the bottom, this is just to sort of give you a guide of what you're going to be seeing, because Dr. Joe will be showing us some cases later on. So these two reports provide information, these two sort of forms of information, the subjective images, which we as radiologists can interpret, and the quantitative information, which can be directly and added to your reports. So that's a very important point, is that everything we build is built from a radiologist culture. So what we do from the bottom up is provide transparent workflows of directly moving information from the PACS, from the device to the PACS, to your dictated report, where quantitative information is passively displayed. Next slide, please. After people say, how do you do it? They say, how do you know it works? Or more importantly, how can I know it works? And there is not enough time here to go into all the evidence that's been generated, but I'd like to sort of give you a framework that we've used in generating the evidence, because it's very important, especially the top two. This framework was partially developed during our FDA clearance process, but we've significantly expanded on it with many, many more cases from a variety of databases and from clinical cases that are being performed both here in the United States and with our research partners globally. Some of you are in the audience, and thanks for attending and helping. Our evidence really falls both into a quantitative batch and a qualitative batch. So we provide direct quantitative voxel by voxel analysis using a predicate technology like SPECVQ and our technology in exactly the same cases and measure the exact voxel distribution of both perfusion and ventilation based on these predicate technologies that are in routine use, but frankly, extremely hard to access. And we'll talk more about that later. We've provided that over thousands of cases and demonstrated high correlation. But we don't stop there. We have reader studies using experienced chest radiologists, nuclear medicine radiologists, and a variety of other experienced readers who actually evaluate at a lobar or segmental level and is quantitatively are evaluated on their reading and have extremely strong direct correlation with the standard of care technologies against which we are comparing ourselves and producing what we believe is a much easier and more accessible workflow. And I think, next slide, I'll end on this slide. I just want to show you one case. You'll be seeing more, but just to give you a general feeling. This is a relatively explicable case that we can see as radiologists from the grayscale image. COPD, patient with a clearly hyperinflated left lower lobe. This was the clinical SPECT VQ study that was performed on this patient for planning for lung volume reduction surgery versus endobronchial valve placement. And the ventilation technology is hampered in many patients because of the particulate matter and clumping. But in both cases, with the ventilation on my left and probably yours, but I can't do the math from behind me, and on the right shows that there's an expected match of both reduced perfusion and ventilation in the left lower lobe. Now, if you could click one more time, please. From the original CT scan, which was already performed. So I think it's really important to understand this CT scan is retrospective. This analysis was done retrospectively. This patient has years of CT scans, and we were able to actually track this patient's condition retrospectively all those times they received evaluation, and were unable to get and to go through the hoops that were needed for a more complex perfusion scan. And we do show that same mismatch on our perfusion scan, which is below the nuclear medicine, and our ventilation scan in that left lower lobe. I'm just going to quickly draw your attention to the upper lobes, however. On the CAT scan itself, they are, and I mean, I'm a radiologist, Joe's a radiologist, some of you are radiologists. What we see on the perfusion and ventilation images in the left versus right upper lobes is actually a surprising amount of heterogeneity. Those two lobes are functioning very differently for that patient. This will be gone into more detail, but I would really like everyone to appreciate that on the grayscale CT image, there is simply no way that one would interpret that study and make inferences about perfusion. And perfusion is at least half of what lungs do. We've been blessed with X-rays and PFTs for 100 years or more, but perfusion has always been out of reach to the vast majority of patients. And yet, critical information about how this patient's lungs are functioning are literally invisible on that CT scan and become, through retrospective analysis, available to you, available to the patients, available for treatment and long-term care. So again, thank you.
Yeah.
That's the end of my...
Yeah, thank you, Greg. I think that really gives us a very clear picture of what CTVQ can produce technically. And now let's shift gears here and talk about this, how this technology really transforms in clinical reality. So Trishul assisted in that FDA validation study, and his work spans COPD, asthma, and helps in the assessment of lung volume reduction pathway. So Trishul has firsthand experience treating patients where nuclear medicine is actually heavily constrained. I'm sorry about that. But Trishul, maybe you could help walk us through how CTVQ in COPD and LVR workups, alongside what we already know occurs with PE sort of assessments, where most of us thought VQ really resided. What happens when you can't get access to that nuclear medicine, and how are you using this sort of information to treat patients clinically?
Yeah, thanks, Matt. And just by a show of hands, how many radiologists in the room? All right, good showing. Any pulmonologists? So I will aim to not clear this room out with pulmonary physiology, but this is very much rooted in pulmonary physiology, right? And so the idea that ventilation and perfusion matching is the basis of how we function on a daily basis. And you can't look at this in isolation. You can't just look at ventilation, because we know ventilation distributes regionally within the lung. We also know perfusion has regional distributions, but it's the comparison of the two that is the basis of human disease. And as Greg mentioned, 1880s, when spirometry came about, and we're utilizing the same technology to diagnose patients with interstitial lung disease, COPD, and a range of other respiratory ailments. But we know that we can't look at regional distribution based off these current modalities. And while all of us, particularly the radiologists in the room, know the value of static imaging to diagnose disease, we can't combine structure and function. And so there's been a huge push within the field to really identify a structure and a functional relationship as it relates to respiratory disease. And as Greg mentioned, the background, a lot of this is SPECT CT. We also have hyperpolarized MRI, and these are all based off of the distribution of a particle, either technetium in the setting of SPECT CT, which we utilize down in Miami, or xenon in the setting of hyperpolarized MRI, and we're looking at the distribution of a gas. And also that transmission of the gas across the alveolar capillary space, or the distribution of a particle injected in the lungs. But the very fundamental component of that is these technologies are expensive, they're not readily available, and they're really isolated to a couple centers in the United States that do this work. And so we run a CTEF program at the University of Miami, which is for individuals that develop pulmonary hypertension after developing the pulmonary embolism. And we use VQ regularly. It's a $1 billion market in the United States. And so there's a lot of these studies being done. However, to get one of my patients on a scanner in order to get that test done usually takes me a couple weeks, if not a month, because that device is really oriented around cardiology. And so I share the same device that the folks in the cath lab utilize for sort of stratifying and doing cardiac procedures. And so saying, hey, I want to do a VQ study in that setting is a major limitation. And I want to take this a step a little bit above and beyond where Greg was talking about. And so the primary indications for VQ currently are really for pre-surgical planning, endobronchial valve placement, and CTEF. And the problem with that is, at least this is my perspective, and certainly the perspective that I think Greg's got when he talks to a lot of people, is that the limitation of the technology, the limitation of applications of this technology are really a limitation of access. And we haven't really applied this to disease entities that could have potential benefit. And so I study COPD and asthma, and getting a VQ study for an asthmatic or someone with COPD is a non-starter. Right? I'm not going to push a cath lab case, to do this for COPD. However, especially in early lung disease, where we can identify regional distribution, where we may not be able to look at disease in static lung, this could have a huge benefit. One of the areas of focus that we are very, very much interested in addition to Philips is deployment-related respiratory disease. Individuals that were overseas in OEF, OIF that returned came back with normal PFTs, normal CT scans, however, had very significant functional impairment. And so when you biopsy these individuals, and these individuals were biopsied about a decade ago, there was evidence of constricted bronchiolitis. And so there was clear pathology that wasn't being picked up on traditional imaging and traditional spirometric assessments. And however, when we do apply functional imaging, and not just obviously 4D's technology, a range of other functional assessments, there is pathology identified. And so how can we utilize these technologies, or how can we democratize these technologies in settings, in rural settings where there's no access to SPECT CT, in settings where individuals with early lung disease, people with COPD, people with asthma can really benefit? Obviously, a bunch of research needs to be done in this space, and certainly within the pulmonary field, as well as I think within the imaging world or radiology world. There's a lot of folks looking into it. But I think the real value here, Matt, is how can this technology be now applied broadly? across the spectrum of respiratory disease and not really be sort of an esoteric, expensive technology, but really a actual diagnostic and longitudinal biomarker for respiratory disease.
Great. Yeah, thank you, Trishul. I think that really brings the clinical impact to care. Now, unfortunately, Amy, as I mentioned, was defeated by the snow and the storms. But from our conversations with her, Greg in particular, can you share some of the comments she made around as a critical care physician treating patients overnight? You know, we spoke to her straight off a night shift at one time, and she said, I had a patient last night. Where were you guys?
Yeah.
What was her perspective on where a non-contrast study and having that democratization of VQ apply?
Yeah, I'm so sorry that she couldn't make it because Amy is a passionate critical care physician and really has excited me about uses of the technology that may not have come to me specifically. You know, this particular patient population that she cares for, which is obviously a very fragile population, this is a population that is more likely than almost any other to have limitations to be receiving intravenous contrast. This patient that she had specifically was in anuric acute renal failure, but not yet on dialysis. And they didn't want this patient to have to go on dialysis so she could do a CT scan. And so at this point, it was out of the question for an ICU patient to go for a VQ scan if it was even available at 10 o'clock at night when the patient arrived. But the patient was receiving a CT scan and could easily be transported to and from the scanner. So really what she described to me, a very memorable moment in the discussion, was when she said, essentially, if I could get a right heart catheterization on any patient who was healthy enough to get a CT scan, how would my intensive care management of these patients change? And for me, that was that, if you've seen the meme of the guy whose head is exploding, that was who I was at that moment. The idea that we could return information that, not from an imaging perspective, required a study that was not available, but from an interventional perspective, all of the work, risk, time, and complications in doing right heart catheterizations, really getting in deeply to the physiology of this patient's cardiopulmonary status, suddenly becomes available with a CT scan. That really was a moment for me.
You mentioned the veterans before, and you know, I would be remiss of me not to mention that Dr. Rose is a very experienced, tenured VA practitioner for critical care as well. But
and deployed.
Deployed, yep, swears like an army trooper, bless her. But that's too much information, she'll beat me up. In particular, how do you see this being democratizing care? You know, the underserved communities, that veteran community that is not in the major metropolitan facilities where nuclear VQ often is. Between the panel, where do you see that playing a role?
Yeah, and I can talk both about pulmonary function tests as well as nuclear meta-imaging, right? And so these are two modalities that actually are limiting. Both technologies, despite the fact that they are necessary to diagnose disease, are highly, highly limited, particularly in rural settings. CTs are not. You can throw them on the back of a trailer, and it doesn't require a respiratory technician to coach someone to do PFTs or nuclear medicine techs. And so we could potentially identify disease at the earliest stage in very rural settings where we just don't have access to PFTs, where we don't have access to nuke med. And what excites me is the idea that we can actually scan or population-based scanning for respiratory disease at a very early stage. And so that's more broad, but obviously for DRRD, particularly within the VA, an inspiratory expiratory CT takes a couple seconds to get done.
Yeah. Yeah, and I think you know, the maths behind this is that there's over 14,500 CT scanners in the country alone, and continuing to grow. There should be more Philips scanners out there. There's plug for our partner, but certainly some on trailers. But there's nowhere near that percentage of nuclear devices, and in fact, the US is starved of SPECT CT in particular. There's still 2/3 of the imaging done in nuclear VQ imaging is done on planar scintigraphy. So we have the ability to really generationally leap technology to provide this clinical service and give quantifiable data that you couldn't actually ascertain off a scintigraphy image. So, not only is there an increase in volume, that examination time goes from being an hour to 5 minutes.
Yeah, and I think also thinking about the data that a patient can get off of a scan that they're doing, right? Everyone is data driven these days, and the ability for a patient to get more data off of a scan that they're already getting done, for me, is kind of a no-brainer.
Great. Okay, so I'm starving the radiology community in the room from seeing some clinical cases. So without further ado, let's connect this back, the workflow, with Dr. Joe here, who's recently been evaluating CTVQ down at Duke in his imaging practice. And I'd love, Joe, if you could share your thoughts with the audience around, you're an interventional radiologist as well. Where do you see CTVQ playing a role in interventional radiology and procedural planning? And then love for you to show some of these case studies too.
Yeah, it's a pleasure to be here, and thank you for having me. And I've gotten to run several cases with the algorithms and looking at this VQ imaging, and it's been very, very, very exciting. It's from the interventional space. I do a lot of lung biopsies, and we do a lot of lung ablations, and we're always very interested in regional areas that could be affected by an intervention. And so I think this would be a game changer, in particular for me, when we're doing radiation planning and thinking about, is that lobe going to be affected due to whatever treatment we're going to do, either percutaneous or radiation. So very excited about that. And we'll go through some images here. So I've really gotten to be very comfortable looking at the technology. And let's take a look at this first case. So this is an adult cystic fibrosis patient. So think about me as a chest radiologist. And the other thing we can talk about that are limited resources are chest radiologists. Okay, we are a very limited resource, and we love that and kind of hate it too at the same time. But when you look at this scan, it says evaluate for CF, and that's the indication. I look at this scan, I'm reading with my fellow. What are we going to say here? I don't really know what to say. Anatomically, we've got what looks like bronchiectasis there in the superior segments of both lower lobes. We have a little bit of bronchial wall thickening and maybe some tree and bud opacity as well. But honestly, my report is going to be very limited. It's going to say, this looks like adult cystic fibrosis, no acute findings, no consolidation. Now we're going to go to the next image. And if you look here, we're adding ventilation to this image. And as Dr. Morogel talked about, this is all relative to the patient. And in this ventilation scan, there is some heterogeneity, but I would tell you overall, it's pretty homogeneous. So a pretty homogeneous study here. And if we look at the next image, this is where it gets very, very striking for me, and it makes me think, as a static imager, I've got to up my game now, taking it from static now to give me some functional information. And if you look at the perfusion imaging there, it is really, really strikingly abnormal, and we can see massive perfusional defects there in the periphery of the left lung. Certainly when I look at that anatomic image to the left, I do not appreciate what I'm seeing on the perfusion image. So one, we have asymmetry, right lung versus left, but in addition to that, there are major, major peripheral perfusional defects, and the asymmetry is quite striking to me. And imagine this making it into a report. Now I've got a really great diagnostic report that's going to say, yeah, there's CF, but I've got major abnormalities here that I wasn't able to see just on the diagnostic scan. And so let's go to the next case. And so this is a classic COPD case like Dr. Mogul looked at. And if you look at this scan, what am I seeing here diagnostically? This is going to be my thoracic surgeon at Duke probably wanting to do a lung volume reduction surgery. And they want to see if there's upper lobe emphysema or see where that emphysema that they could take out that would benefit the patient. And on this coronal image, we can appreciate that there is a fair amount of upper lobe emphysema. We'll go to the next image. And here we get the ventilation and the perfusional images here. And again, relative to the patient, when you look at the ventilation imaging, what we can see there is a little bit of heterogeneity. And the actual area that's getting ventilated is really towards the lung bases. And there is some homogeneous ventilation also in the apices as well. But where I really want to shift us to is looking at the perfusional images there. And if you look at the perfusion image, you can really appreciate that the apices of the lungs are not getting perfused. But even within that, when a surgeon is making a decision about which lobe am I going to take out functionally for this patient, I would argue the right lung has decreased perfusion relative to the left lung. You can see that area on the medial aspect by the aortic arch has more perfusion. So these are all the kind of considerations that go into a discussion when we're having a group discussion in our tumor boards about lung volume reduction, or even in a cancer patient and trying to see what lobe they're going to take out. And then we'll go to the last case here, which is a case I love. So this is a CTEPH case. And you want to talk about something we never do. We never do non-contrast imaging for CTEPH, right? All of our cases are with right heart injections, and they're looking to see, hey, has the burden of clot improved? Has mosaicism changed? These are very, very difficult cases for a diagnostic chest radiologist who reads a whole lot of chest CTs to be able to give any functional information. So looking at this case here, this is actually a patient with CTEPH. The thing I would tell you that's striking probably to everybody is there's a fair amount of emphysema here. So a lot of emphysema, but also chronic thromboembolic disease. And if we go to the next images, so if we look here in the ventilation scan, again, there is some heterogeneity, and you can appreciate that in the apices as well. And I would tell you, I work with Sudhar Rajagopal in our center, who's a big right heart person at Duke. And he's always like, Joe, if I could get some functional information out of you all to figure out these new treatments that are being brought to us all the time to see if they're actually making a benefit, that would be tremendous. And if you look here on the perfusional images, there's massive asymmetry, right? The right versus the left lung, we see way more perfusional defects in the right apex than we do in the left lung. And I would tell you, the thing for me is I would functionally be able to give that in a report. But now that we have these new treatments, we could actually follow this patient and say, did your endarterectomy work? Did your right heart treatment work? And do we actually have a change in this patient's images? And again, I can't emphasize enough, non-contrast imaging is huge in this situation. In particular, this is something we would never do. I was actually very happy I was able to find this case of a CTEPH patient with inspiratory and expiratory imaging, because we don't really do many of these.
Great. Well, thank you, Joe. I think those cases make this very clear what we're trying to achieve. But last but not least, James, let's move to the enterprise level, where really this success depends on having access to data, how that's integrated, and a unified workflow. So, James, how does a technology and something, say, delivered through the partnership of Philips and 4D Medical here accelerate the adoption of clinical informatics and make advanced functional imaging available to these communities?
So I think this question of access is really key. And some of the examples you gave, obviously for Philips, we are a modality company as well, but we specialize, especially in this group, in informatics, which is centered on data. So I'm gonna take a different route from all the clinical speak that we've had here, and I need to talk about data for a second. Through the path that we've been through historically, we all started in a digital world, right? And there was this transformation from analog to digital. And if you think about, in comparison, let's say, to the dashboard on your car, you have had analog dials there. You've got digital stuff that was transformed back in the 80s, but it really didn't tell you anything different, right? It didn't give you different information. It was just in a different format. But it was able to be captured, and that's key. So then we started capturing all this data, but data by itself doesn't mean anything. Now it's got to be interoperable. Things have to communicate. So again, with the car analogy, if I can have my engine speaking with the drive system, now I've got something going here. But nevertheless, interoperability matters. I've got systems talking to one another. They have to play nicely. But what does that mean for the patient? That's when we move to a phase of insights. And where we sit now, what we've been talking about today are insights for physicians, clinicians, and others in the space, right? What we really want to bring to the table is intelligence. And from a Philips perspective, this is our path. This is our philosophy. And our statement is we want better care for more people. when we enter this age of intelligence, now we have actionable insights. And philosophically, this is how it dovetails with everything that you've heard today with 4D Medical. Because now I have data, but it's actionable data. And in fact, it's helping me with clinical decision support, as you've heard all the analyses here. So now I've got comprehensive analyses from the data that is helping me ultimately with the patient. Greg mentioned earlier, look, all of the technology here that they are using is numeric, right? It's not AI-driven. It's analytics and quantifiable data. However, from an imaging perspective, then we can take those outputs and do all manner of things from a digital imaging system, from an intelligence system. And now if I have AI agents running and analyze even further, I'm going to have better outcomes for the patient. So this is an excellent complementary partnership that we have here when we're talking about VQ. It is so integrated into what we do for patient care and from a modality point of view, as has been mentioned again, and then access. So we've got greater access at reduced cost, right? Which for the patient, which is at the end of the day, the most important thing, I've got safer lung imaging.
Great.
And greater output. So from a Philips perspective, this is a very good match.
Terrific. Thank you, James. I'm actually going to jump in on your car analogy there and borrow that even further. So remember, this is a software layer. So it comes in at the pack. So, slotting into the Philips packs, we're not having to connect to all those 14,500 CT scanners out in the wild. We don't have to install new hardware of nuclear medicine to deliver this. So the analogy we use is, imagine Tesla when they were inventing the electric vehicle. If they weren't competing with gas stations around the country, they had all the chargers already deployed as mobile phone chargers. That's kind of what we're looking at here, is every CT scanner, every PACS is already deployed, and you're now getting access to functional physiological imaging off the equipment you've already got in the field. So, Greg and Trishul, I'm going to sort of open up to a quick dialogue with the panel here. Where have you seen the biggest impact so far clinically of CTVQ from the discussions we've had so far?
Yeah, I mean, I think it'll be in existing modalities, right? CTEPH is clearly an example. Endobronchial valve placement, lung volume reduction, which in of itself is a massive market, as we discussed. But my interest is actually expanding 10, 20-fold beyond that. And so thinking about how we can utilize this for early respiratory disease, longitudinal biomarkers of disease-specific treatments, precision therapies. That's where I think the true value of this is, particularly now that we have much more lower radiation approaches to imaging. And Greg can probably follow up on that as well.
Yeah, I think there's the current limitations and problems that exist around the disease states, including both acute and chronic thromboembolic disease, are kind of legendary. If you can walk around this meeting and find anyone at this meeting who tells you, I'm really pleased with how we're managing the question of acute pulmonary embolism right now. Seems like we've got everything we need, thanks. Then please introduce me to them and I will have them admitted. There is no one who believes we have the armamentarium that we need to take care of that problem, let alone what is to many radiologists a relatively invisible problem, to be honest. The constraints and inability of physicians to get the perfusion studies they need to keep operating rooms functioning, to keep bronchoscopic suites functioning, and the simultaneous rise of the multidisciplinary team as a factor in the future of radiology, I think cannot be understated. This brings radiologists not just as the PACS person to the MDT team, because I remember when I was doing those all the time, most of what people counted on me to be able to do is bring up the images reliably and figure out how to window and level them. now, the real decisions, especially in the age of AI, I think are going to be driven significantly by group human intelligence. The data can come from AI, but the group at your hospital where you are working and providing solutions to these intractable problems, like these complex pulmonary vascular conditions, the value to the radiologist suddenly is you significantly bring together this new intelligence into the decision making. That will not be replaced, in my opinion, anytime soon. The ability for an AI agent to perhaps quantify, I think will be. So I think that on the one hand, very immediately, we're, unlike many of the solutions you'll see at this conference, we are solving an immediate, real-world workflow problem for patients to get the specific care everyone knows they need. And we as radiologists simply can't stand in the way of that. But the upside, once pulmonary functional imaging becomes available at a completely retail level, every patient who's receiving care in a tertiary care center, who may live 3 hours away, and I talk to a lot of radiologists here. I live in an urban area, but I talk to a lot of radiologists here whose patients have to drive 3 or 4 hours back and forth for every additional study. But they have a CT scanner often in their neighborhood today. And that image can serve as the basis of the highest level quaternary care information. And I don't know what we're going to learn about human lung disease having perfusion and ventilation information for every case.
So I've heard from the panel a couple of times around workflow, and particularly we mentioned the interventional pulmonologists doing these reduction therapies and the surgeons. In terms of workflow, they're the biggest champions you can have for implementation. We all know how challenging it is for an IT department to deploy one more project, right? So having that engagement from the referrers that are making a lot of money for the facilities, for the procedures they're doing, as well as good patient care, they're your biggest ally in getting deployment of this technology. Joe, you mentioned about that workflow and referrer engagement and your referrers. How do you see the role of a radiologist really getting strengthened in terms of that referrer and giving them better physiological information?
Yeah, I think a lot of points to that, and I think Dr. Mogul brought it up really nicely. We have to have a multidisciplinary approach to these patients. Radiologists can't be just in the background reading the scans, and I think that's probably the biggest thing I've learned with chronic lung disease in the last 10 years. In particular, we haven't even talked about interstitial lung disease, and that's a whole topic in itself. And so, I would tell you that these surgeons, the interventionalists, they want to come to us for us to give them the information that they need to treat these patients. And I would tell you, if we can do that, that completely changes our relationship with them and makes us a member of the team.
Great. And anyone on the panel, please jump in. What excites you about the future here the most? What is it? Is it non-contrast delivery? What's the most exciting future you can see that we haven't even thought about with this technology?
So I'll start off, but I'm sure everyone in the panel actually probably has this component. I think my interest is really the future, right? Is how we can actually apply this so broadly within respiratory disease and really reimagine the way we identify disease and track disease. For those of us that have worked in the field of spirometry and have been doing this for close to a decade plus, it is a limited modality, and a lot of us have been thinking about how we can consider replacing that.
I think I've heard enough from you.
No.
I'll say what to do. Yeah.
The only thing I would add to that is I am a big proponent of subclinical disease. That's where we need to be. I think Tricia would agree with this. We've seen it with interstitial lung disease. We want to identify patients who aren't having symptoms, but I'm seeing something on a scan, but I'm not seeing that on a scan. But with a VQ image, I'm sure we'd be able to see those things like we've seen with deployment-related lung disease.
I'm going to come back to the word access, because we can go deeper into communities that don't have access to technologies like this, that require contrast, right? And so, but to your point, there's a proliferation of CTs all across the country. And so, and we can be mobile with it. So the deeper we can go into communities with a technology like this, more people will be served.
Great. So I think we're coming up to time. So I'd like to thank all our panelists, Greg, Trishul, Joe, James, and Amy in absentia. But thank you for being here with us this morning. So if you'd like to continue the conversation or to see CTVQ in action, please come by and visit the 4D Medical booth in the South Hall. We're at 1759, or stop by the Philips Hall. They're right over the other side in the North Hall at 6730. So please enjoy the rest of RSNA and have a great morning. Thank you.